Hi, this is Austin Nakatsuka at the University of Utah Moran Eye Center, and I'll be presenting a technique of filleting or opening up the anterior capsule to remove Sommerings ring. The author has no financial disclosures regarding this presentation. Having a sizable practice of pediatric patients who are aphakic, I run into this problem a number of times where we see a large Sommerings ring, which is representative of microscopic lens material that has proliferated, as is known to happen in the pediatric population. The problem with leaving this material behind when inserting an intraocular lens is that this material can be so bulky that it can push the lens into the iris, causing iris rubbing and a uveitis glaucoma hyphema or UGG syndrome, or it can impede vision itself if close enough to the pupil. This is a technique to remove that Sommerings ring material before placing another lens to avoid these complications. After filling the anterior chamber with viscoelastic, an MVR blade is used to make a few cuts in the anterior capsule to access this material. After this is done, the irrigation aspiration device is used to gently remove the material. In this case, I first use the coaxial IA because it can typically handle larger pieces of Sommerings material. However, I eventually switched to bimanual IA as this allowed me easier and better access to all of the material in the capsular bag. You can initially start with bimanual IA if you want to access 360 degrees of the capsular bag. I use a 20 or 23 gauge MVR blade depending on how large the eye is. When making cuts, I am very careful not to hit the posterior capsule and I stay fairly close to the center of the capsule and do not extend to the periphery to avoid damaging any zonules. When removing the Sommerings ring, try to stay within the capsule to avoid losing any material into the vitreous space. Many of these cases have an open posterior capsule due to a primary capsulotomy that had been done when they were babies. After most or all of the material is removed, you can see that the capsule is much more clear and the view is far better. There is also far more room to place a lens. In this case, I placed a 3-piece lens in the sulcus space and felt this was very stable and well centered. This is another similar case. As you can see in both cases, there's an area of fibrosis in the center where the anterior and posterior capsulotomies have been done. The capsules have fused together here, and this can create a very thick but stable structure. I fillet or cut open the anterior capsule to access the Sommerings ring just peripheral to this fibrotic tissue. The capsule is much thinner here and easier to cut. You can make multiple cuts or you can sweep side to side with the blade to get the cut and access needed to the Sommerings ring. It is important to try and remove as much of the Sommerings material as possible, as it can stir up a severe inflammatory response once it has been liberated from the capsule. However, there may be areas where there is fibrosis of the capsule, and I typically will leave these alone as these provide structural support. When inserting the lens, I will sometimes use an anterior vitrector to widen the capsulotomy, and then I will optic capture the lens, meaning that I will leave the haptics in the sulcus and I will push the optic edges through the capsulotomy. This produces an even more stable and centered lens. However, that can be a bit risky in these cases as you sacrifice the stability of your central ring of fibrosis, and sometimes the thin peripheral capsule will tear when you're trying to push the lens posteriorly. Overall, your goal should be a clean capsule with a stable and centered lens that will produce a good visual outcome for years to come. Thank you kindly for viewing my presentation, and please feel free to contact me if you have any further questions regarding these types of cases.